All right, welcome back, everyone. Uh, Good morning. I am very excited to introduce our second keynote session of the 2023 AOC Annual Convention, Be the Best You Can Be and the Patient Wins. For this session, we are honored to be joined by Dr. Robert Geiser. He is a professor of anesthesiology and the core program director in the Department of Anesthesiology at Yale School of Medicine. Primary interest is in obstetric anesthesiology. He's a member of the American Board of Anesthesiology, serving as the current president. He also serves on the 3C Committee of the American Board of Medical Specialties. Dr. Geiser is a board member for the Accreditation Council for Graduate Medical Education and a member of the Executive Committee. He also serves on the Committee on Academic Anesthesiology for the American Society of Anesthesiologists. Please join me in welcoming Dr. Geiser.
Great. Thank you so much, Alan. And thank you, everybody. You know, it really is a pleasure to be here. I really want to give also a shout out to Dr. Fabro, who invited me. And it's funny when you think about this, that I look at what I just heard, and of that I am proud, but what I'm most proud of is when I see my residents whom I work with accomplish so much. And I say that seriously, Mike. I hope you know how proud I am of you and your accomplishments. And my hope is that in later life you'll still remember me and some of the things that I've taught. So what we're going to do today is we're going to try to figure out how to become the best. And you know, one of the nice things about getting old is that I get the right to pontificate. So yeah, I'm going to pontificate a little bit and just realize you're humoring an old man. So what we're going to do is we're going to develop a plan to deal with colleagues. If I had to say the one thing that my training did not prepare me for was dealing with colleagues. Colleagues has been the most challenging aspect of my job. We're going to invest in colleagues for optimal outcomes and understand the adult learner and really work on improving our intraoperative environment. So let's look at society, right? We have a contract with society. The society expects physicians to address the health needs of individuals, and they expect us to be altruistic, moral, and competent. So what do we get in return? We get social status, respect, autonomy, and the privilege of self-regulation. Professionalism is this basis of this contract. So we have a contract with society, and professionalism serves as the basis and to meet these expectations of the profession of the society. And since I knew I was coming to Florida, you know, I did have to work a little Disney in, and you can see by my tie with the Mickeys on it, I am a Disney fan. The contract isn't always upheld. RL did uphold the contract, but a lot of times it's not. So what is the problem we're talking about? Well, let's take a look here. So here we have an individual who, anesthesiologist, who beat a 12-year-old up on the ski slope and used his ski pole as a weapon. These are all I just Googled. So this was an interesting case. This was a patient who was so worried that they weren't going to remember what the doctor told them, kept his cell phone in his gown and kept it playing. So this was a gentleman who was going in endoscopy, and what we see here was that afterwards he was quite shocked by the comments that the anesthesiologist made about the patient's habitus, the patient's social status. Sued and was awarded $500,000, although had a great outcome because of the comments made. And then, gotta do this. I mean, anytime I see an open IV bag, I don't use it, right? And in this one, this is even scary because these bags weren't still in the plastic, where an anesthesiologist tampered with IV bags, killing another doctor. So, do I need to move closer? Better? All right. Had to move Dallas anesthesiologist. So what happened was that another anesthesiologist came in not feeling well, gave themselves a liter of fluid, and in that liter of fluid was local anesthetic, and the person died. So we clearly see that unprofessional behavior exists, and I gave you the extremes. However, there are a lot of unprofessional acts that are occurring within our work environment. This was a survey sent to attendings, residents, nurses. And what's amazing is that, again, I'd ask you, are you surprised the number is 63%? And when I ask you, are you surprised that it's so low or that it's so high? Right? And what you can see here, everybody has experienced it. Residents tend to be the target, 2 times the target of unprofessional behavior, and our women colleagues tend to be more discriminated against than others. So we have to be aware of this. It is occurring. And don't negate the effect. There is an impact of this unprofessional behavior that affects the patient. So this is a fascinating study. So this was where they did simulation of pediatric teams. And what one team did, they just did it, and the other team, they had a person who sat there and said, does this guy know what he's doing? Does this individual know what they're doing? Just constantly making rude comments throughout the resuscitation. And then they compared the performance of the teams. And what you can see that the ability to diagnose, and it's a little small, but what I can show you is I can attest to is that this ability to diagnose, diagnosing shock, diagnosing necrotizing enterocolitis, and diagnosing cardiac tamponade was much slower, more likely to be wrong. And the only difference was one person standing there making obnoxious comments. So we do know this bad behavior does impact the patient. What is this problem with unprofessional? It really leads to decreased information sharing. So this is a slide, and I'm sorry about the pictures, it's kind of small. The references there, I hope you get a chance to see these and look it up. But what you find out is that everybody's had a chance to experience it. And the clear take-home message, people don't share as much. People become more quiet. And it is that what creates the problem, right? Because there is no question about it that medicine is a team approach. And if not all members of the team are participating, you lose a valuable insight. What's interesting, too, is that they noted in there was surgeons, and that surgeons who were more likely to have bad behavior, more likely to experience complications when they looked at their definition of complications. So again, very interesting. Is it the fact that they're a less skilled surgeon that leads to this? Or is it the fact that when a surgeon is misbehaving, there is less likely of exchange of information between the anesthesia team and the surgical team? And then it really does affect our residents. So it was very fascinating. So these were residents that were in simulation, and in the simulation they were normal or rude. We would just call it rude, right? Where people were treating them nicely, not addressing them professionally, things you would just call rude. And they looked at the vigilance, diagnostic abilities, and communication, and those 3 were the most affected. So what's interesting, they noticed that team, they were less vigilant and they weren't communicating. The big problem was that the residents didn't know it was affected. That's the scary part, right? So we know these actions do affect people. The problem is the people don't see it, so they can't compensate for it. They left the simulation thinking they were just as vigilant, just as competent in diagnosis, and a same level of communication. So we do know that this type of behavior will affect the patient. Is disruptive behavior inherent to the physician or environment? And it's both, right? Our environment does create this situation. This was an interview of events involving unprofessional behavior, and we know that as the acuity increases, the incidence of having an unprofessional action increases, right? So, and when you think about it, as an anesthesiologist, all of ours actions occur in these high intense environments. So it's very interesting. It really does have an effect of our specialty more than others because of the fact that as the intensity increases, so do these unprofessional acts. And they do state that there's some question about what are the policies, and there are always competing interests, but that's not a reason to forgive it. And again, we're going to take a look on the impact of these behaviors to show Houston, we do have a problem. This was a survey sent to multiple specialties. And the risk of having PTSD in terms of being a physician is higher. No difference among specialties, and that we know that the younger residents, women residents, and anybody who had a public embarrassment were more likely to have this PTSD. There is some good news, right? A survey sent to residents, it turns out that they were, currently this is from 2023, 24% burnout, 15% depression. And I'm happy to say it was lower than it was in 2018. So we've gotten a little better. This attention to wellness has helped, but we still have a problem. And I'll tell you that there's certain things that you'll never forget. So I was a CA1 resident, and I'll never forget the time period where I just, it was my second month. I got the tube in on the first go, and I was waiting for the attending to congratulate me. What I got was, at that point, the attending, who I still remember his name, announced to the surgeon that there will be delay after this case. And I said, because his anesthesia resident touched the machine without taking his gloves off, and therefore this machine was contaminated. And not only was I to clean the machine, he watched me clean the machine. Talk about public humiliation. I'm happy to report I've never done that to anybody, but I can tell you the name. I can even still see the room in which it happened. So absolutely amazing of this impact that we talk about. So we also have to remember something about dissonance. And so, yeah, you'll have to forgive me. I do like Judge Judy. No longer on TV. Well, she is on TV, but that show just isn't as good as her original show. And one of the phrases she would say is, if it doesn't make sense, it probably isn't true. And boy, that goes there, right? Because if it doesn't make sense, it doesn't make true. Because that's what we're talking about, dissonance. So now we're going to do a study, okay? I'm going to randomize two groups of people. They're going to perform the most boring task you can think of. I want you to think of what you think is the most boring. One group's going to get paid $20 to do it. One group's going to get paid $1 to do it. Who do you think rated that task as interesting? Remember, it's the most boring. Do you think it's the most paid, the higher paid, or the lower paid? Well, it turns out it's the lower paid, consistently, because your brain says there is no way you would have done something this boring for $1. It has to be more interesting than you thought. And this is consistent over groups, over age groups, over training. We don't like dissonance. We'll fix it in our head. Here's another example of dissonance. If I ask you to read the colors, you'd go very fast. Try to say the colors, right? You have a hard time. Your brain knows it's red, but you're seeing yellow. And you want to say yellow, and you'll go through this. The brain doesn't like dissonance. It'll do everything in its power to correct that. So, I'm truly, truly fortunate to have had the pleasure of knowing the Huffnagels throughout my entire career. And they know that my love of obstetric anesthesia, and one of the things that we used to do during my time period in Philadelphia, it was every other month our OB people all through Philadelphia met, and it was extremely helpful to learn. So I am going to focus a little bit on OB, and we're going to take a look at 10 anesthesia providers and 10 obstetricians. We're going to send 4 rounds of questions with feedback. And here are some of the things that create dissonance on the labor floor. We do notice that there's the lack of appreciation of anesthetic risks, right? How many just put them to sleep. Just put them to sleep, right? They don't understand it. Management of high-risk patients. Complete things. Miscommunication between anesthesiologists and obstetricians. Timing of cesarean delivery. Uterotonics, exteriorization. And then you have to give them a little bit, right? Variation in NPO policies amongst providers, right? We know if you had something solid, it's 6 to 8 hours. But we also know it's 6 to 8 hours depending on who's covering the labor floor. And they know it, right? They know this person will do it in 6, this person will do it in 8. Should ever a care be dependent on who's covering the labor floor? No wonder they go bonkers, because they don't know. And we are guilty of it too, just like we feel they don't understand the anesthetic risk. So what we're talking about, a lot of this, is communication. Communication is the key to our specialty. Here's an interview with surgeons, anesthesia providers, nurses, and communication is critical. And we know that lack of cordiality, lack of engagement, distractions will all affect. This is one of my favorite cartoons. You got to love this, where you have here communication. And that is why we lift on 3, right? Because the patient fell. So let's show what happens when communication breaks down. So here they're doing epidural. So again, apologies to my cardiac group colleagues out there. My pediatric probably haven't seen this in a while. But for those of you, what I can share with you, this is bad. This is the fetal heart rate. This is bad. That's the only thing you can do. And I am so thrilled because I see my colleagues, the Huff and Eagles, going, yeah, that's really bad. And this occurs during an epidural. And what happens is, how do you manage it? So it was a simulation, obstetricians, anesthesiologists together. What did they find out? We're really good at saying what's going on. I am having a hard time getting the epidural in. So we're very good about advocating information. We're very good, I'm going to do a spinal. What they noticed, we're not very good asking them, what's your plan? What are you going to do? Do you think this is going to be longer? What do you anticipate? As compared to obstetricians, they're very good at advocating, and they're very good at asking us, right? So one of the things that I learned from this, and this study changed my practice, I'm not shy about asking questions. Now, I'm going to use common sense. If I hear the suction going and the canister is filling, probably not a good time to ask a question, right? Because I want them to focus on what's going there. But when I hear it going down, I'll always say, can we do a pause to see where you are and to see where I am, right? And the other question I will never do, and I have worked really hard with them, I can't stand the question, how's she doing? Right? It annoys me because it's a very judgmental question, right? It's, I know more than you do what's going on. And when they do ask it, I will afterwards pull them aside. Now, what they're trying to say is they have a concern. Better to say their concern. I hear the saturation is reading lower. Is there anything I can do to help? Is much better than, how's she doing? Because what is the response to how's she doing? Fine, right? Always, right? And so they've learned that, and we work on that. But the same thing, we should do that. Never ask your surgeon, how you doing? How's it going? Right? Better to say, I have a concern. I have a spinal anesthetic. I can't tell you, but I think you only have about another 30 minutes. Is there any way you can go faster? And if you can't, I would like to induce general anesthesia now. Much better than, how you doing? How's it going? We have to be very careful about that. And don't hesitate to speak up. Again, the consistent thing in the literature is that anesthesia providers are very good about advocating, but not very good at asking. So if we can leave here just going and asking, we're going to be better off. So what do we know about communication? Well, let's look at malpractice in obstetric anesthesia. So here's 263 claims, and of these, 76 claims involve newborn brain damage. And the one thing that's consistent is, look at that, second cause, poor communication. So we think that it's the substandard, but in reality, this communication breakdown leads to bad outcomes. And this is consistent through the literature. 43 claims for obstetric hemorrhage, 1995-2011. Greater severity of injury compared to other claims, death. And look at this. Yeah, okay, timely diagnosis, 30%, 1/3. 2/3 had a communication breakdown. And it's a breakdown on both sides. Because I guarantee, if the suction was going, we said, how's it going? And they said, fine. And they asked us, how's it going? And we said, fine. Communication was done, right? So we have to be careful about that. When the communication breaks down, patients get harmed. So I love this study. This is a recent where they looked at barriers to communication. And the reason they did this in the ENT room because in the ENT room, sometimes they put the drape up, sometimes they didn't. And they noted that if you put the drape up, the communication between the anesthesists and the surgical team was a lot less. And in fact, if there was no screen, it was 250% better. Absolutely amazing. Now, I'm also guilty of this, and I'm going to share this little tidbit because I know Dr. Faber will remember Dr. Rosado. Dr. Rosado was a surgeon we worked with who would always complain about muscle relaxant. And what we would do is that anytime he complained about the relaxation, we put the drape up higher. And so it was not uncommon to walk in the room with a drape almost at the ceiling, right? Because he complained all the time. But it was not the right. That did not lead to better communication. And in fact, it really probably upset him more than anything. And we have to be really careful how we communicate with patients, right? We go and we tell them we're going to do our pre-op. And I thought this was great. What are some of the things that people don't understand? We're going to give you some sedation. What is sedation? Reflux. What is interesting, in this study, it's a little old, but no one understood what aspiration is. Our concern is aspiration for we're going to do this. What is aspiration? They did have a general understanding of reflux, but they didn't understand anaphylaxis anesthetic agent. It's not, when you're there, just say, any questions? What did you understand? Is there anything I can repeat? Do you understand what we're going to be doing? Follow up, but use terms that people understand. And we have to communicate better with each other. One of the things that we work really hard, right? The one thing that my things is, again, I work with the residents because what's the phrase? They'll say, can you give me some feedback? And what's our response? You did fine, right? Not very helpful on either end, and nor is it the way that they should phrase it. It's, can I give you, here's my reaction. Here are the things I liked. And I'll always say the same thing. Feedback is to make you more like me. Who's to say I'm right, right? This is my opinion, and you should incorporate it. But I think the most important thing we can do when we communicate with colleagues is get rid of this word. Get rid of but. I can't tell how many times, what's going to happen here. Hey, Bob, that was an awesome lecture, but I would have. The minute you said but negates anything before it. So it really wasn't an awesome lecture, right? So be very careful. When you did a great job today, but I would have. You didn't do a great job. So the better way to phrase this, hey, today you did a great job, and I would have done this. Same thing when we're talking with colleagues, and probably I've learned the most important, talking to my spouse, right? This dinner is delicious, and she knows now. And my other favorite story, because of the outcome, was I preached this to the residents. The one resident met me the next day. She's crying, and what's wrong? She goes, she was talking to her boyfriend, and his phrase was, I love you, but. And she dumped him. And the only reason I'm able to share it is because she's now happily married, not to him. But it was funny that I didn't think I would be breaking up relationships with this phrase. But it is important about that when we communicate. So my hope is you come away from here being willing to speak up, to share with individuals, and don't be scared to ask, right? And be directed in your asking, because you're not providing a front to your surgical colleague. How's it going? It kind of puts them on the defensive. I have a concern because X, can we, and then you'll get a much different response. Let's talk about judgment. Well, I love this because judgment comes from experience, and experience comes from poor judgment, right? So it's kind of the horse and egg. I'm going to take you through this scenario. So we have, our relief time is around 5 o'clock, so we changed responsibility at 5, and my relief came in at 5:20. We had a little discussion between the two, and what's interesting is the RL. RL is our incident reports. The incident report is filed. Now, who files the incident report? You would think it's the person, who was sitting there in the OR for another 20 minutes, couldn't get home. Oh no, it was the person who was late, because the individual was relieving acted unprofessionally. So what occurred here? Well, the problem is that fundamental attribution error. So what are we talking about with this? This is the tendency to attribute the causes of other people's behavior to their intrinsic nature. Right? When we heard the story of the late, what was going through everybody's head? A little lazy, right? Not very good. Should have came in earlier, right? We all thought kind of negative. We attributed. Did anyone think about a car, something outside, right? Did we think it was that there was traffic? No, it kind of goes that. Whereas when it's within us, we tend to attribute it to external behavior. I can't tell, there are so many people walking around the United States thinking they have scoliosis because the anesthesiologist couldn't get the epidural in on the first pass. Can't be me. It's your back. How many times have I been called to take care of a patient because the last time, and they said, oh, they told me I have bad scoliosis. Bad scoliosis. Oh, jeez. And the great news is you look good because you just put it in on the first go. But how stressful was it for the patient, right? It's your fault. It's not my fault. I'm going to ask you, what's going through your head now? I want you to think about it. Honestly, answer honestly. You're watching the preoperative nurse put an IV in and he misses. Who thinks he missed because he's just not as good as you? Yeah. Thank you. I see a couple of, yeah. And deep down, you're thinking it, right? You are thinking it, right? Whereas, what do you think about when you miss? You're placing IV and you miss. Oh, patient's dry, right? They have bad veins. Patient's fault, right? Who thought bad veins when it was the pre-op nurse? So be careful about this. We tend to attribute things that occur from others. It's intrinsic to their nature, and it's never positive, right? They're lazy, they're not as good. Whereas when it's with us, it's always external. You know, in my time period, I've been a program director, Dr. Fabro and I talked. I'm going on like 20 years. And in my 20 years, I have never had a late person ever arrive late because they overslept. It's always traffic, right? It's never their fault. Always that. So I think it's interesting. We've got to be aware about that. Other things, so we have Miss X. She's a 34-year-old G1 who had an epidural placed at 3 centimeters. She's a difficult patient. She's really tough. She's gotten multiple boluses. When a C-section is required for fetal heart rate tracing, the epidural catheter does not work and she requires general anesthesia. Is anything of this a surprise? No, right? Because what we're seeing here is this confirmation bias. Watson's confirmation bias. What are we trying to say? So we're going to do a little experiment. With every letter, there's an associated number. Okay, with every letter, there's an associated number. I'm going to propose the hypothesis. And they're unique. They're unique, right? The hypothesis that with B is associated with the number 4. What card are you going to turn over first here? Who would turn over B first? Nobody. So we see something in the back. And who would turn over 4 first? And who doesn't care? There we go. So it turns out that if you were to combine the B and 4, almost all the population is going to go to that. It's not that's interesting. The question comes up, what is the second card? Let's assume you turned over a B and there was a 4. What's the second card you're going to turn over? So you did the B. Who here would turn over the 4 to see if there's a B? Well, you already proved there's a B associated with 4, right? It would be better to do an E, right, to see if there was a 4 behind it, or an 8 to see if there's a B. That's Wasson's confirmation bias. You only look for information that supports your conclusion. You're going to neglect anything outside. So when we go back to this case of the woman who had an epidural placed, well, of course the epidural didn't work. You're a difficult patient. And the fact you're proving it's difficult, right? I don't see the fact that the epidural is not working. You only see things that support the conclusion you made. So, and this is what we're talking about, this tendency to seek out evidence that supports our existing beliefs. The worst thing, the thing that drives me up the wall the most as a program director is listening to the faculty, break room where they're talking bad about residents. Because the minute they say something about that person, everybody in the room only knows them as the bad resident. That's why when I work with my residents, the first time I say, you have one first impression. Make it good. Because I can't tell you how many people are stars, because everybody says they're a star and you're working with them. They're not that good. But you kind of look the other way. And it goes almost a good year before you realize that they're not performing. And the poor person who got labeled as bad really has to work really hard just to be deemed adequate, because we only see the things that we're looking for. That's what we pay attention to. So I'm going to tell you, you're signing out. And sign out, they tell you, oh, that patient 317, she's difficult. I can tell. Nothing will make her happy. But the great news is 319, she's the nicest patient. You're just going to love her, right? So now you get a call that both of them require a bolus, right? They need an epidural bolus. What's the first thing that you're thinking about? Who here would give 319 a bolus? Yeah, right? She's nice. 317, ugh. You're not going to look at it. You're going to assume, if 319, you're going to think that maybe the catheter's not working. Whereas 317, it's the fact that, you know what, it's just that you're difficult. And we know this. This confirmation bias can go harm. 2016. So I know it's a while ago, right? But not that long ago. 2 elective surgical patients died after esophageal intubation. And because the fact is, they saw the tube go through the vocal cords. They saw the tube. So they saw things that confirmed it, right? Hey, there was chest movement. They heard. There was fogging. Oh, by the way, no end tidal CO2. Really? Well, it was the CO2 monitor wasn't working. Or there were bronchospasm, right? You only see the things you want to see. So it harms. 69 never events. The most common etiology of these never events, unwanted retained foreign bodies, wrong site, wrong implant, is this confirmation bias, where you become overconfident, you only see what you want to see. And it really has a factor. Epidural for labor, 83% white, 63% black patients get epidurals. Epidural failure, it's more likely to fail in the black population. Is there an unconscious bias here? I don't want to say, but it's interesting, right? But black women are less likely to have their pain and anxiety taken seriously. Why don't black women choose epidurals? Well, there's the fear of complication and distrust, which seems to be supported by this study. So let's take a look at some heuristics and how they can get you into trouble. These heuristics are these, your brain has to do a lot, right? There's a lot of information. What you're going to do is your brain loves shortcuts. Let's look at some of the shortcuts and how they get you. So I'm going to tell you right now, we have a group of 70 engineers and 30 nurses. Okay, so there's 70 engineers and this nurse and 30 nurses. One member of the group is this 30-year-old woman. She's married, she has 2 children, she's very skilled, she's motivated, she's liked by all, and let me tell you, she's incredibly successful. Who here thinks she's an engineer? Who here thinks she's a nurse? Hey, what? So there's 70 engineers in the room, 30 nurses. What is she most likely to be? Yeah, but it is, now that we say it, but when you go through the heuristics, she's liked, right? The minute I said she, people went right to nursing, right? Because we have that. That's your brain shortcut. Here's a case that's taken from the literature. G5, P5 woman, out of bed, gets out of bed on day 1 after her 3rd C-section. She's obese. She has 1+ pitting edema, and she did not take her sub-Q heparin. She rapidly loses consciousness and develops PEA. What happened? PE, right? So they had to coagulate her, at which point she bled to death because this was a bleed, right? And the problem, right? Everything seemed to suggest it, and that's your heuristic. You jump to it, and you got to be careful. You got to watch about that. Anchoring, where you focus on that first thought or exposure, disproportionate to the other things. What am I trying to say? I had a G1P0, severe preeclamptic, undergoing C-section for failed regress. This is my case. During the case, I bolused her epidural, and now we're 40 minutes after the epidural, and she's becoming progressively hypotensive. What's going through my head? Oh, it's the epidural injection, right? It has to be 40 minutes later. And I came to the diagnosis, and I fixed on it, and I missed everything because I fixed on that. I missed the hemorrhage. And when they checked her hemoglobin, and after the fluid bolus, I'm happy to report she did okay. But I fixed on it. I was absolutely convinced it was that, and that. So that anchoring to that first. And then you got to watch out for the zebras, right? I'm always going to get a platelet count before I do an epidural because a colleague of mine had a problem in a patient with low platelets. That problem is so rare, but because of that, we're going to focus on that. And, framing, right? We're really influenced by this. So what we have here is these two people discussing, and, on this one, they're like, we're going to reduce carbon emissions, right? So this person, it's awesome. We have reduced carbon emissions to 3%. Well, this person says, it's kind of only 3%, right? We're presenting. It's how you present it. So be very careful about all these things because they're going to influence you in your care. And don't forget the negativity bias, right? Humans are more attentive and influenced by negative. And we know that, hence that leads to unprofessional. When that attending made me wash the machine, did I ever touch the machine without taking my gloves off? Absolutely not. And to this day, I think about that before I do. So it worked, but at what cost? And we know this, so that's the problem with this negative. Negative reinforcement as compared to positive reinforcement leads to very fast learning. That is very resistant to extinction. And we know that in medicine, but it comes at a cost. And this is that unprofessional behavior, and they know it. And what's interesting is that the viewpoints, this was a survey, and the only reason I threw it in there because I like it. So when they interviewed the faculty, they said it's very important to avoid unprofessional behavior, where students say I have a water here, I'm good, thank you. Where students say it's very important to do professional. Interesting, right? Both same accomplished, but the way they view it. So, I did tell you in Disney, now I'm going to tie in Beauty and the Beast. Don't lose hope, love. If you do, you lose everything. So I don't want you to lose hope. I think one of the most important things we can do is develop our emotional intelligence. This is where we monitor our own and others' emotions and discriminate amongst them. And that really helps when guiding thinking. And it's definitely been shown that if you have a higher emotional intelligence, you have better doctor-patient relationships, better empathy. Stress isn't as bad, and you become a future leader. So how do we develop professional behavior? Well, we develop this emotional intelligence. We increase our awareness, accepting personal accountability. Own it. Right? If there's a mistake, it's okay. I own it. Create the willingness to experiment, to break through the barriers, and develop relationships. As I already said, one of the joys, I walked in here, and somebody remembered me from their residency when they did a 1-month rotation with us. And I can't tell you how awesome that made me feel. Right? Relationships, so important. It's the key to the working conditions. It's a core competency. And we already covered the communication aspects. So what can we do? Go out there and become a leader. Leaders are examples. What are the key things to leadership? Be honest, forward-looking, competent, inspiring. What we're trying to say is don't command commitment, inspire it. What is leadership? A leader is one who knows the way, goes the way, and shows the way. Right? You don't have to be the chair to be a leader in your department. You can be a leader in your department by acting professionally and being a role model for your other colleagues. What do other organizations have to say? So you already heard my disclosure. I am involved in the ACGME. I am involved in the ABA. But there are skills, just so that you know, if you have a resident coming from ACGME, management skills to include basic knowledge of organizational culture, decision-making, change management, conflict resolution, negotiation advocacy. Didn't exist when I was a resident. Unheard of. It was about giving drugs. Now we realize it's this teamwork. And in the ABA, for the advanced exam, they'll have to learn about crisis management and teamwork. And then part of the exam process is an OSCE, where they actually have to go in and demonstrate. And there is going to be more and more communication with professionals. One of my favorite OSCE is where they have to tell the surgeon they're going to postpone their case. And the standard patient's pretty awesome. So because of my role, I get a chance to watch them. So before the poor candidate walks in, they generally will either be doing jumping jacks or anything to get a sweat. So when the door opens, they already encounter this SP who has this sweat, their face is red, and the first thing they say, I hear you want to cancel my case. So it's quite interesting to watch. What can we learn from the leaders? I think we can learn about their styles, and I think it helps us become visionary and managing our time. I can't emphasize this most. Become an educator, right? Teach your colleagues, teach your patients, and teach. It's awesome. It's a great way to give back. Here's some advice that somebody gave me, and it really works regardless of where you are. But it's advice that I always give our new faculty, but it works anybody. I tell them, think Tums, right? Tums. Whenever you have an interaction with anybody, talk with them, not at them. Now, I'm guilty here because I'm talking at you, but it's an unnatural conversation. Hopefully, we'll get a chance to talk afterwards to give me the chance to talk with you. But talk with them. Use their name in a positive way and ask them something personal about themselves, right? So important, right? Learn about them, right? It isn't that you know their name, but it's like, hey, how is this? Make eye contact, smile. So anybody here working with residents, I can tell you, it's that easy. You want your evaluations to go up? Just remember Tums. Talk with them, use their name, remember something personal about them, make eye contact, and just smile. It really is that easy. Become a mentor. Really important. Now, we think mentors are academics. There's mentors in private practice. There's mentors everywhere. We all have mentors. Mentor in the field can be a great boon when it comes to one's calling. These are comments that come from medical students. Mentors really improve career satisfaction. So it's really funny. You want to make yourself happy, become a mentor. And it helps both people. What are the keys to success? These are goals, being clear. And the reason you'll fail is you have very different goals. And we already said it. It's this, a mentor walks alongside you to show you what you can do. Here I am. I'm very fortunate. These are three great leaders in the field. Sanjay Datta was one of the founding fathers of obstetric anesthesia. When I was a CA1, he looked at me when I still had no idea what I wanted. He goes, "You're going to become an obstetric anesthesiologist." And to know Sanjay, all you could say is, "Yes, sir." And sure enough, there I was. And then these two people were Philadelphia, where the Huffnagels and I had a chance to work. So I know these both very well. Dr. Cheek and Dr. Gucci. Both of them are just very kind, showed me how to love the specialty and just really how to be happy. So isn't it amazing, right? I'd love to tell you, and they did, don't get me wrong, they taught me how to do academics, how to lead, but I think the most important they taught me was how to be happy, how to have a great career. Because what I'm telling you is, what is your hedgehog principle? I want to ask you right now, what is your hedgehog principle? What is a hedgehog principle? Well, a hedgehog principle is this concept of the fox and the hedgehog. So when the fox wants to get the hedgehog, the fox will try running at the hedgehog. The fox will sneak up on the hedgehog. The fox will jump on the hedgehog. All these different ways. What's the hedgehog do? One thing only. Curls up into a ball and puts out its spikes. So what I'm trying to ask you, what is that one thing that defines you? Right? What is your hedgehog principle? And that will help guide you in your decisions as you go forward. And never forget your hedgehog principle. Got to have it, and that will help you as you go forward. Know your mission and just do it. What do residents want? This was a longitudinal survey sent to residents, and of the milestones, residents had the highest confidence in professionalism. They do want an appropriate balance between service and education. And it's a really biggest challenge for those in academics now. Will tell you that for residents, the hardest thing now is they're viewed as a workforce. With the shortage, it's understandable, but they're not there to be a workforce. They're there to learn. And so my biggest challenge is trying to always protect them, as there's that. And now they're very smart. Now they don't go outright. It's just a slow creep. Can we start a little earlier? Can we go a little later? But we all experience it, because I have news for you. It's the same thing for me. Can we, we used to turn over at 5. Now it's 5:30, and soon it's 6. And once they realize they got not in the night, they're going to move to the morning. Can we start at 7? Can we start at 6:45? Watch out for that, because that does affect professionalism. So I'm going to ask you, how do you go about improving your professionalism? So I love this study. And this is a psychology study. There were 3 groups. So the students were randomized to 3 groups. Group 1 is your control. Group 2 was told to just go say thank you. Anytime somebody does something nice to you, show some gratitude. Hey, thank you so much. And group 3 was told to do random acts of kindness, right? Make sure you hold the door. And it isn't just hold the door for the person behind you. Hold the door for that person that's still halfway down the hall where you could really pretend you didn't see them, but they know you saw them and you close the door on them. Do these random acts of kindness. What did they show? I think it's really funny. We talk a lot about wellness and how to improve wellness. Turns out that just being gratitude, demonstrating gratitude improves your wellness. You'll have a lot more positive emotions. So a thing to take home from this, remember, be grateful. It will help your emotions, your positive emotions. But the thing I love fascinating is the people who did the best in the class were the groups who did random acts of kindness, right? These actions really improve your engagement in what you're doing, right? So this combination of gratitude and random acts of kindness really is the key to success. You're going to have a positive attitude and you're going to be the best you can be. So does anybody recognize this picture where this is from? This was the Little League World Series, not this year, the year before. And what had happened, they just got started, and here's the pitcher, and I didn't do videos because the problem videos always get, but what he did, he beamed this kid. I mean, outright beamed him. Went down, wasn't sure he was going to get up. Guy gets up, goes to first base. So he's standing on first base, and he notices the pitcher is crying because pitcher beamed him and beamed him really hard. What typically happens in modern baseball, in professional baseball, the guy leaves first base, goes out and just belts, right? Goes out and belts. So what he did is he thought he was coming to hit him. What he was doing was just giving him a hug and saying, you know what? I forgive you. Don't beat yourself up. And it's been interesting because you follow these kids through years. So what's interesting that this poor kid has been classified, they say crying, and they call him the hugger. But what both of them did was establish what is really true professionalism, right? I got to first base and looked over at the pitcher and saw him with a glove over his face, Jarvis said. I saw his face somehow and could see he was crying. So I dropped my helmet and went over there. And again, it wasn't over there to hit him, it was over there to hug him. And it's a reminder to us, random acts of kindness really go the long way. What prevents you from being the best? Well, the impediment to action advances action. What stands in the way becomes the way. And I love this phrase, right? You can become better. I have news for you. It's not hard, right? Understand these heuristics. Here's some takeaway points. Really, remember, act professionally. It's so important because it improves communication. And understand it, right? Now that we know this, we're going to watch for this when our colleagues are acting unprofessionally, that we don't shut down, right? Probably not the best time to point it out, and I was guilty of that, and it was a little bizarre. I know he didn't mean to, but the obstetrician, I've never been hit. I got hit pretty hard by him. And I said, just don't hit me again, but we talked about it afterwards. And he was so anxious. He thought he was just tapping me on the shoulder, and when he saw me falling to the ground, he realized he had hit me pretty hard. I didn't hug him. I really didn't feel like hugging him at all at that time. But we also didn't let it interfere, right? We still continued the communicated afterward because I knew it, right? I was able to monitor my own emotions, which were anger, right? I was so angry. And I was able to then say, now, afterwards, I did let the anger come out, but in the OR, I kept it. And I felt we had good communication, we had good outcome on a really very sick patient. Really, I think the most important thing, just so that you're aware, most people in there are unaware of the uneffects of uncivil behavior. So now that you know that, you can monitor for it and you can create a better environment in that. We are more likely to attribute an error, a deficiency in the individual to the environment, right? So when we see something within us, it's the environment, but when we see something by somebody else, it's intrinsic to their nature. Watch out for that. You're only going to see what you're looking for. Remove that bias, and that will help. And saying thank you improves your mood. Doing acts of kindness improves your engagement. Again, I can't tell you how honored I am to be here. When Mike asked, I was thrilled beyond belief. I'm so humble to have to be here to present, and I do want to say a thank you to you. Thank you very much.
All right, thank you so much, Dr. Geiser, for this informative and excellent presentation. If you have a question for Dr. Geiser, please come up to one of the floor microphones to pose your question.
Or you could just raise your hand. Okay, go ahead, and I'll repeat it in the mic. So the question comes up is, when you witness unprofessional, such as going to the break room where, let me tell you, the break room probably is no different than the teacher's room in schools, right? So here's the problem, right? The problem is they do have to vent off steam, right? We have to allow that, but you got to tell them to self-monitor. And so what I'll generally do afterwards, because the nice part, I do have good relations, I won't call them out. I leave, I'll go back, and I'll say, here's this. And then I always give the example. What would you be thinking about if the residents had a break room and what they were saying? And it's always very interesting, because at that point, they're very unprofessional. That's the same. Remember, when you hear someone, you attribute it to, they're unprofessional. And then you say to them, that's kind of what you were doing. And it becomes very eye-opening. I understand it. There's that balance. They have to blow off steam, right? Especially when it's been rough. But we also have to, and don't ever say but, and remind them that you are creating a bias. And we really have that. We currently have a poor resident who had a really rough start. And he is having a hard time digging out of that hole. And when you take a step back, he's awesome. But because because he had that incident, I told him, you're going to have to work harder. And he accepted it. But yes, you do have to address it, right? Because if you don't, you've condoned it. Yes.
Thank you, Dr. Geiser, for a very engaging talk. I have a question. We talk a lot about professionalism and a lot of similar talks like this, right? And as you said, everyone makes this a priority. But we do know there are negative patient outcomes in an unprofessional environment. The aviation industry has looked at this for a long time, and human factors and crew resources management. Are there lessons learned from them that we can take away in an organized fashion to implement training programs, policies that would impact this more definitively?
Great question. So I saw that was a mic. So really what's interesting is it's a kind of more just spreading the word, right? I think the most important thing is that knowledge, right? The aviation industry has learned that every single one occurs almost universally from a breakdown in communication. Very, very rarely is it equipment failure. Equipment failure is there, but it's consistently, and where there's this breakdown. And because there is a breakdown, people feel uncomfortable sharing. I'm thinking about I'm going to show my age, the People's Express was a clear breakdown in communication. They're literally telling, but it wasn't occurring. And so what do we do about that, right? So we emphasize communication, we call that, and yet we don't understand that when we're in an uncivil environment, that stops. So how do we fix that? What we have to do is make sure that people are aware, and even if it's an uncivil, be able to speak up. I think we're going in the right direction because there is a greater empowerment, a greater emphasis than when I was. And I'll never forget, I had an attending tell me that you're the anesthesia resident, you are to be seen and not heard. And I'll never forget that. I think we can correct that by empowering and setting example. And yet I do know when in that environment, if we just let it play out, there'll be the breakdown in communication. And how do I don't know. Because we've even seen with simulations and stuff, because they don't recognize it, they won't know it. And again, the one thing I love is the people don't realize, some people here will remember the stethoscope. The austere piece in the esophageal. Yes, thank you. So what you had to do is, that's the only reason, and you stood right there. There was none of this sitting on a chair behind. You had to stand right there, and that's where that concept of heard, seen, not heard, because you stood right there. You couldn't wander far because you had that. And does anybody here remember checking blood pressures every 15 minutes yourself, not the machine? Yeah. Yeah, every 5 minutes, yeah.
You mentioned my name several times, so I have to tell just a small Dr. Geiser anecdote myself. I think everyone gives a testament here that you're quite the mentor, and I do remember even as a medical student getting shuffled off to the chocolate place in Philadelphia, and you asking me what I learned that day, and I still use that today. Unfortunately, I have found all the residents learn the same thing, which is a lot, and that's the answer they always give me no matter what. But what I wanted to ask you about is you talked a little bit about the creep and being asked to get more from the residents, start earlier and later. And we talked about a lot of hats you wore, but we didn't talk about the fact that you were just a chairman recently. I know you're not doing that anymore at the University of Kentucky. You're now at Yale. But can you talk a little bit about that balance you had to play as a chairman of meeting the efficiency targets, but also staying a strong resident advocate, which is obviously at your heart?
Yeah, so Mike, that in essence summarizes the aspect that makes the job of a chair the most horrible, right? Right now I have the best job. All I have to go to the chair. You can't do that to the residents, right? And the chair has to fix it, right? The problem comes is someone has to do it, right? And how do you fix that, right? I have found the one thing that is clear: money doesn't work. Money is a Band-Aid. It makes you feel good for a couple days, so no matter how much you offer to stay late. And then it becomes a priority, right? Watching the waste and making sure it gets fairly distributed. Does it work all the time? Because nobody thinks it's fair. But if you try to make it as fair as possible. So the one thing is that not all rooms are always running late, but that you make it get evenly distributed. That is a key factor. Trying to work to that fairness. But that involves a lot of work, right? You're in there, you're watching, and you're constantly having to make changes. And there's the problem is the board runner has their bias, right? Who are they going to relieve first? The person who's never given them trouble, right? Sits there, or are they going to relieve the person who complains all the time? Yet it really is fair because the person who complains all the time was there the latest last night. And that's where it's hard. So you have to educate and mentor them that you may have your bias and you're not rewarding bad behavior, but what you're doing is being fair to everybody because everybody contributes. And does it work? No. You know, the one thing that's amazing, but it allows you to sleep. It allows you to say to the leadership, I've done the best I can, right? And that is all I can do. And they still will want more, right? As they should. And once you go to bed realizing that dealing with them are like dealing with your kids. After Christmas, you're expecting them to say, or whatever holiday, after whatever holiday where they got all these gifts, are you happy? No. I didn't get, are you serious? Right? It's never, ever. Once you realize it's never going to be enough, it really is extremely liberating because no matter what you do, it'll never be enough. So, stop.
I had one quick question. I know we're almost at time, but confirmation bias, I have a lot of interest in that. Can you give us a short OR pitch of how you can reduce confirmation bias with residents?
Yeah, so being aware of it, right? And, you know, the one thing that so with residents, but I'll tell you, on the labor floor, I got rid of the difficult patient. I'm so proud to say that we no longer have difficult patient there. Now we have to say, what do we get rid of with the difficult resident? And the problem will be is you can do the best you can. What is better to do it is to tell the residents you get one first impression. So my very first thing when I was working, I was just working, I said, Jason, you have one first impression. Make it good. Now it shouldn't be that, and we should be aware of it and spread the word, talk, but it's very hard.
Yeah. All right.
All right, thank you.
Yeah.
Thank you so
Yes,
much.
yes. Please round of applause.